Hello, this movie is to talk about breast cancer staging, and in particular what the radiology resident, fellow, or faculty really needs to know. Here are the learning objectives of this video: to be able to identify the key radiological features on mammograms, ultrasound, CT, and breast MR which affect staging, to recognize patients in whom advanced imaging is indicated, be able to identify features of locally advanced disease, to be able to compare the radiological features of stage 1 to 4 disease, and finally to understand how radiological, clinical, and pathological staging interact to affect treatment. And just to note that the staging in here is based on the AGCC cancer staging system, version 9 for breast. So that comes from the American College of Surgeons. And staging clearly matters, as you can see by this little graph here. The 10-year relative survival for breast cancer decreases dramatically when you move from stage 0 through stage 1, 2, 3, and 4. And just to note, staging is complicated. The clinical staging, the TNM, or tumor, node, and metastasis staging, which you're all familiar with, is the preoperative or the pre-neoadjuvant chemo, which includes those radiological features. But then there is a pathological TNM staging after resection or after neoadjuvant treatment, and these may not be the same. And then to further complicate things, there is prognostic staging. And the prognostic staging includes the grade of the tumor, the ER, PR, and HER2 status. And this is really the most important staging criteria. So you can have a patient who is a clinical stage 1 triple negative, who may have a poorer prognosis than a clinical stage 2 ER positive, PR positive, HER2 negative tumor. And this does allow individualized therapy, however. And here's an example of just such a case. So this is a patient who had a triple negative tumor, seen here, identified in June 2023. She underwent surgery. She declined chemotherapy or radiation therapy, but she had widely negative tumor margins. Here's her initial baseline post-surgical scan 6 months after surgery in December 2023. And here, only 6 months later, there has been a recurrence that's actually larger than the original tumor. Because of the complexity of the disease, breast cancer really does require a multidisciplinary approach to both staging and management planning. And this is going to involve, at a minimum, surgeon, oncologist, radiation oncologist, radiologist, pathologist, and geneticists, all of whom get together at multidisciplinary tumor boards to discuss patients. The TNM staging is profound because it's going to affect the type of surgeries performed. So does a patient get a modified mastectomy or mastectomy? Is their nipple resected? Is there an axillary nodal dissection or a sentinel node resection? Is there local whole breast or nodal radiation? And does a patient need some form of chemotherapy, either neoadjuvant or postoperative? When as a radiologist you look at the AJCC TNM staging for breast cancer, it's a pretty scary document with lots of granular detail in it. And I think it's very off-putting. Obviously, this is not something that we're going to memorize. But here's the important thing. As a radiologist, we do not need to do the final staging. There are calculators, which I'm going to show you in a minute. But the radiological information is very key, and the most important things are going to be tumor size, the presence or absence of any chest wall or skin involvement, the presence or absence of any nodal disease, as well as the presence or absence of any distant metastases. And we're going to be going through all of these in order. Here's an example of one of the online staging calculators that you can use. It's QXMD in this case. And you go in, it asks you all these questions. You just click on the specific answers that apply to this patient, and it's going to come out and give you your 10mm calcification as well as the prognostic stage group, which is super helpful. So let's go through the TNM staging for breast one by one. So starting with tumor, the T. T0 is when you don't identify a primary. So this is usually a patient who presents with axillary metastasis and whom after a thorough workup they can't identify any primary. TIS is in situ disease, DCIS only. T1, 1 to 20 millimeters of invasive. T2, 21 to 50 millimeters invasive. T3, more than 50 millimeters invasive. And T4, when there is chest wall, no, not pectoral, and we'll come back to that, invasion, skin invasion, or inflammatory breast cancer. Just a couple of notes on measuring tumors. The tumor measurements usually come off ultrasound or MRI, sometimes off mammography, but you should always use the maximum dimension. If it's by ultrasound, they should include the echogenic halo around a tumor. We don't include satellite nodules that are within 2 centimeters from a primary tumor, but we do separately measure nodules that are more than 2 centimeters from the tumor. And these maximum dimensions may not be our standard planes, and may not necessarily be standard transaxial or sagittal imaging planes. We really should rotate that probe or have a look at things on MR until we can find our maximal measurement. T1 tumors can be further broken down into T1A, B, and C with gradually increasing measurements, as you can see here. Here's an image of T2 and T3 tumors, which are not broken down further, with T2 being 20 to 50 millimeters and T3 being greater than 50 millimeters. But T4 is further broken down to T4A, which is when there is chest wall involvement, T4B, where there is skin involvement, T4C, where there is both chest wall and skin involvement, and then T4D is inflammatory breast cancer. There is a category called locally advanced breast cancer, where generally these are inoperable at the primary site, but don't have distant metastasis, and usually going to require some form of neoadjuvant therapy to shrink these tumors down prior to surgery. The definition of LABC seems to vary between different trials, but a sort of good definition is a T3 or T4 tumor with any end disease, so big tumors or ones that have skin or chest wall invasion, and then any tumor that has either N2 or N3 nodal disease that we'll talk about in a moment. Just to mention quickly a little bit about the diagnosis of inflammatory breast cancer. This is primarily a clinical diagnosis where more than a third of the breast skin has erythema and peau d'orange, and it is defined, as we said before, as clinical stage T4D. It can be diagnosed by the presence of tumor emboli within a skin punch biopsy, but you don't have to have this for the diagnosis. And you usually have to have some kind of a tumor biopsy to be able to have full histology and receptor studies, even in the presence of a positive skin biopsy. Just note that locally advanced and ulcerated cancer is not the same as inflammatory cancer. So this patient, who obviously has a very locally advanced cancer with a lot of skin ulceration and necrosis, but this, although there is some degree of mild inflammatory change that you can see in the skin above here, this is not an inflammatory cancer. That is just a skin reaction to the degree of ulceration. On the other hand, this is a patient who does have an inflammatory breast cancer. Their breast is enlarged, it's got a lot of erythema, it's got peau d'orange going on here. More than a third of the breast is involved by this process. And the skin biopsy in this case did show inflammatory breast cancer. And this is what this is going to look like on MRI. This is a subtraction image. You can see that on the right breast, there is marked thickening as well as enhancement of the skin of the breast, lots of trabecular thickening and irregular enhancement throughout the rest of the breast. Nodal involvement in breast cancer most commonly goes to the axillary nodes, both level 1 and 2, and I'm going to be talking about these levels a little bit later on in this presentation. This also includes the interpectoral or Rotter's nodes. They may spread into the infraclavicular region, level 3, internal mammary, supraclavicular, and then to other sites such as mediastinal and cervical. And here's a diagram just demonstrating these nodal levels. So the ones that we most commonly see are the level 1 axillary nodes. Here are the level 2 and level 3. and then supraclavicular nodal group, and not uncommonly we see the internal mammary nodal group. If you remember from the earlier TNM staging slide, nodal levels are divided into N1, N2, and N3 clinical nodal categories. These are further subdivided, as you can see here. I'm not going to go into these in detail, but just to know that the level 1 and 2 nodes that we commonly detect on imaging, if they're mobile, are N1, but if they're fixed or matted, are N2A, and the higher levels of staging depend, as you can see, on whether infraclavicular, internal mammary, or both groups are involved, or perhaps one of these supraclavicular nodes. I don't think anybody needs to memorize these. It's just that these are areas that we need to look for nodal involvement. As with all TNM staging, metastasis, the M for TNM is 0 for no metastases and 1 for distant metastases. Now we've had the outline of the TNM staging, what information do the oncologists, the surgeons, the radiation therapists all need from us? Well, on the initial imaging, which is going to be usually some combination of mammography and ultrasound, they need to know the maximal tumor size, as we talked about, whether the skin and nipple are involved, and possibly whether there is any nodal involvement, and we'll talk more about that in a sec. They need to have the primary biopsied, usually in breast. We're going to do this with 14 gauge or greater core biopsies, usually 2 to 4, and we may be biopsying the any abnormal node if requested by the surgeon, and this is a complicated topic that I will touch on a bit later. So many of you may be doing breast MRI, either routinely or in selected cases, to stage your patients with new cancer diagnoses. But just so you know, this is controversial. It is used very variably across the country. It's even used variably within my institution between different surgeons. We do know from a number of studies that about 15 to 20% will have additional either ipsilateral or contralateral tumors if you do this on all patients. However, mortality effects have been significantly limited in these larger studies, perhaps because the patient groups selected have not been the ones that would most benefit from this staging. So what type of patients would most likely benefit from staging breast MRI? Those with invasive lobular cancer, because we know that this is frequently multicentric, it frequently is occult on conventional imaging. Patients with triple negative cancers, younger patients, possibly those with denser breasts, patients who have inflammatory cancers, patients in whom neoadjuvant chemotherapy is planned for monitoring, and then those patients who present with axillary nodal metastasis with an occult breast primary on mammography and ultrasound. Staging breast MRI is excellent for showing us chest wall and pectoral involvement. We do see nodes well if the patient is positioned appropriately within the scanner, but the resolution is limited. It's less than ultrasound, so it's often quite difficult to measure cortical thickness and look for small cortical bumps. The size of tumors is often larger than that seen by mammography or by ultrasound, particularly with invasive lobular cancer and DCIS. But studies have shown that staging breast MRI can over and underestimate the size of specific tumors. So when you're reading a staging breast MRI, what information is needed by the clinicians? Well, obviously the tumor size, again, maximal dimension, both mass and non-mass enhancement. The presence or absence of any satellite nodules in my direct surgery and any additional lesions in either breast. If abnormal nodes are seen, they want to know the sites, axillary, internal mammary, supraclavicular, etc. How many look abnormal, because this may affect management, and what levels they are. As I say, we'll talk about that in a sec. And usually, unless these nodes are grossly abnormal, you want to confirm this by ultrasound due to its superior resolution. And that also will aid in the guidance for any planned biopsies. You need to say if there's any chest wall and pectoral invasion, nipple and skin involvement, and obviously if any metastatic disease is picked up, liver, bone, the sternum, we not infrequently pick metastases up in, and lungs. So here's an example of a retroareolar mass, which clearly has direct involvement of the nipple. That nipple is not going to be able to be salvaged. You can see that on both planes there. And here is a posterior tumor, which is involving pectoralis. You can see some enhancement of pectoralis as well as tethering of it here. No, pectoral invasion is not chest wall invasion. Chest wall invasion is when it's going to go back into the intercostal muscles or serratus anterior, as you can see here in this patient. Pectoral invasion is important to notice because it's going to affect the surgeon's approach. They may need to take a small amount or more significant amount of pectoralis, but it does not have the same connotations as chest wall invasion. And here are some images where you can see the tumor. This is the clip from the biopsy is directly invading the overlying skin. Note, again, this is not inflammatory breast cancer, but it is a locally advanced breast cancer. This patient has thickened skin. You can see how thick the skin is. However, it is not enhancing, but it is very high on the T2 image, and this is skin edema. In this case, it was some extensive nodal involvement of the axillary nodes producing lymphedema. And just by contrast with that, another patient who has inflammatory breast cancer, in this case, again, you can see this very thick skin. There's an obvious large mass within the breast. And in this case, there is enhancement of the skin as well as skin thickening, as is typical for inflammatory breast cancer on MRI. What about advanced staging with bone scans, CT scans, or PET scans? Well, these may well be driven by any specific trial protocols the patient may be on. Some general guidelines for advanced imaging are these, though. Stage 0, 1, and 2. Generally speaking, it's only done if there are symptoms or signs that may raise suspicion for metastasis, such as bone pain or raised liver function tests. Stage 3A and above, a bone scan and a CT of the chest, abdomen, and pelvis. And then stage 3 and above, some recurrences, they may do an FDG PET. So this is the FDG PET scan on the patient with inflammatory breast cancer that I showed you a few slides back. So she had a lot of uptake in that breast, as you can see, including uptake in the skin. She then had multiple nodal groups, so including supraclavicular, internal mammary, and mediastinal nodes. So she's N3, so that makes her T4D, N3, and then multiple osseous and hepatic metastasis, so which is M1, so this makes her stage 4. I'm not going to go into this in great detail, but there are a number of elements of the tumor pathology which is going to affect staging and treatment, including the presence and absence of estrogen and progesterone receptors and HER2 expression, the mitotic grade with its low, intermediate, or high, and then oncogene testing. There are a number of different commercially available oncogene testing. One is Oncotype. This particular system involves the testing of 21 genes that are expressed on the tumor samples. They're combined into a single score, and it's used to try and decide whether patients would benefit from chemotherapy if they're low risk. So it's typically performed on patients who are ER/PR positive, HER2 negative, less than 5 centimeter. So you don't do this test on patients who have locally advanced, triple negative, metastatic tumors, etc., because those are, by definition, higher risk and are going to have chemotherapy anyway, regardless of their oncotype diagnostics. So let's come back here to talking about axillary nodal levels, because this is some information that we can tell the surgeons when we identify them by ultrasound and MRI or even CT. So there are 3 axillary nodal levels, 1, 2, and 3. Level 1 is defined as being lateral to pectoralis minor, not major. Level 2 is posterior to pec minor. And level 3 is medial to pec minor. And let's look at some examples of how these appear on our imaging. So looking first at MRI, here's the patient's primary tumor in their breast. We can see pec major clearly labeled here. We can see pec minor. And here is a group of abnormal nodes, and these are lateral to pec minor, so they are level 1. Level 2 would be back here, and level 3 would be medial to pec minor here. And we can see pectoralis minor and major very nicely on MRI. Here's an example of an abnormally enlarged Rotter's node or an interpectoral node sitting here between pec major and pec minor. And this is a level 2 node. This patient also has multiple level 1 and level 2 nodes. You can see here coming behind pec minor. While this patient has multiple abnormal level 1, level 2 Rotters, and level 3 nodes seen here, which are medial to pec minor. And those are not surgically accessible. Always remember to take a look for internal mammary nodes. You may see tiny 4 or 5 millimeter internal mammary nodes normally, but anything much bigger than that is usually abnormal. Just as a hint, they're often very bright on the T2 images, so it's a good place to just kind of scan up and down your T2 images as well as looking at the breast. And if you're reading a CT on these patients, it's exactly the same thing. You can see here diagrammatically shown level 1, 2, and 3 nodes. And again, this patient, you can see some abnormal nodes in level 2 and level 3. Ultrasound, to my mind, is a little trickier. It takes a little practice to start distinguishing between pec minor and pec major. The arms are also in a different position, which does affect how it looks. But you can, again, clearly identify level 1 and 2, and usually level 3 if you look for them very carefully. But as I say, it does take a little bit of practice, and it's worth scanning up and down and making sure that you can identify those muscles. Now, when you're evaluating the axillary nodes, a couple of things you need to pay attention to. Well, first of all, the size doesn't matter if they have normal morphology. You can frequently have 2 or 3 centimeter fatty replaced nodes with thin cortex, particularly in diabetic patients or obese patients. But as long as that cortex is thin and regular and there is a fatty hilum, that's okay. The kinetics on MRI don't matter. So we're used to looking at washout type 3 kinetics and thinking that's suspicious in the breast, but in the axillary nodes, that is normal. They nearly always have a high T2 signal if they're normal. They may lose that high signal if they're abnormal. What's really important is the morphology, which I'm going to show you some examples of in the next slides. It's also important to the surgeons to give them an idea of the number of abnormal nodes, because patients may be managed differently if they have 1 or 2 nodes abnormal as opposed to 4, 5, or 6. So what can abnormal nodes look like? Well, normal, we're used to our kidney bean shaped thin cortex and a fatty central hilum. That fatty hilum can be completely replaced. Note that it can be difficult to assess this on very small nodes by MRI. You can have diffuse thickening of the cortex, and usually more than 3 millimeters cortical thickness is counted as being abnormal, but this is probably the least specific sign of an abnormal node. Reactive nodes often look like this. We can have cortical bumps outside or internally, and then you can have extranodal extension, which is usually shown by an ill-defined or irregular border to the node. So here's an example of a nice normal node. We've got nice fat in it. We've got a feeding vessel. We've got thin cortex. Lobulations are okay. Look at things in both planes to make sure whether it's a lobulation or it's actually cortical thickening. 2 different patients with obviously abnormal nodes. We have a partially imaged big fat node here. This one also looks abnormal. This is probably a normal node. Back here, multiple abnormal nodes. I can see at least 4 here. And this is an example of extranodal extension, this irregular, ill-defined border, kind of a shaggy border to the node. This has focal cortical thickening. This is the same patient, but I think it shows a nice correlation between the ultrasound and the MRI. So a normal bit of cortex here, but very focally thickened here. You can see the same thing here, focally thickened, where there's a normal thin piece of cortex here, and the fatty hilum is still perfectly preserved here. This one is diffusely enlarged and round. This was also metastatic involvement. And one more example here. This one both have focal cortical bumps on them, and you can see those bumps prominently on the ultrasound. And obviously that is the bit that you want to biopsy if you're going to biopsy, not the normal nodal tissue back here. Now, some centers routinely ultrasound the axilla in every patient who has a possible or diagnosed breast cancer. We don't. So what I'm about to describe to you is the policy of our breast center. This is constantly in evolution based on the results of randomized clinical trials. The management of the axilla has absolutely changed since the Z11 trials came out. And now we only ultrasound if there's a larger mass, usually 5 centimeters or larger, if it's an inflammatory breast cancer, or if the patient has abnormal nodes shown on some other form of imaging, such as mammo or MRI, or on clinical exam. Now, when do we biopsy these nodes preoperatively? Again, this is our particular institutional policy, and again, it may change with time. If there's 1 to 3 nodes abnormal, we don't biopsy. But we may do a targeted excision by either needle localization or seed for the time of surgery. Greater than 3 nodes, we would biopsy. There are some exceptions to this, however, including patients who are going to undergo neoadjuvant chemo. They usually want to have those biopsied, which would include patients who have triple-negative tumors, HER2-positive tumors. Let's talk about a few guidelines and hints for axillary nodal biopsies. So 14-gauge biopsies are going to be much better than FNAs. We don't do any FNAs nowadays. Try and get 2 or 3 biopsies of the most abnormal area of the nodes we talked about, not the normal context. Generally speaking, we only sample 1 node, and we go for the most abnormal node unless we can't get at that one, in which case it would be the second most abnormal node. You must leave an ultrasound visible clip there. All the major manufacturers have clips which are much more visible on ultrasound, such as the Twirl or the Hydromark. And this is because if the patient goes to neoadjuvant chemo, that node will frequently disappear, and you're only going to have the clip. But the surgeons usually want to do targeted node excision in this case by either needle localization or seed placement. Depending on how high up into the axilla the node is, this is definitely tiger country for doing nodal biopsies. They can be quite challenging on occasions. You've got a lot of important stuff, vessels and nerves up there, and the nodes themselves are frequently very vascular. These nodes may be deep. If you have ladies who are larger, they can be quite difficult to visualize and quite difficult to visualize your needle. So some things to think about. You can use a smaller gauge needle, such as an 18 gauge, if you're really concerned about it. Consider, instead of deploying the needle with the spring deployment, going in with an open chamber. So you're having much lower risk of going into a vessel or some other major structure. My word of caution with this is sometimes they really push away from you, so they can be quite challenging. Come in with a long, shallow entry pathway so you can see that needle, and then use Doppler with abandon. So here's an example of a nice vascular node. You might want to maybe use a little bit of Lido with epi in this case, and you can see the needle nicely within it, and this was metastasis here. With these deeper nodes, I often do what I count as an L shape, although it's really a backwards L. Shaped needle path where I'm going to pop down a centimeter or 2 and then lever my needle over and go across. So I've got a much better pathway. You're going to get much better needle visibility in this case and less risk of running into something nasty. So I'm going to finish out talking briefly about sentinel node biopsies. So this is the detection and the excision of the first draining node in the axilla. When a sentinel node biopsy is done, they're not done in patients who have palpable adenopathy. They're not done in DCIS, apart from very occasionally if there's very extensive DCIS and they're concerned about microinvasion. And then it's now not done in some low probability invasive cancers, again, based on the results of the Z11 and other trials. And so there are nomograms out there online, which the surgeons can use to be able to get informed discussion with their patients as to whether they would benefit from a sentinel node biopsy or not. And there are obviously risks involved with sentinel node excisions, the main one being lymphedema. So older patients with low-grade, smaller tumors may not, despite them being invasive, may not currently be having sentinel node biopsy. And the concept of this, I'm sure you folks are all aware, is that a radioactive substance, a dye, or ferrous particles, in the case of magtrace, are injected usually close to the tumor or in the subareolar area, and then they drains into the sentinel lymph node, and those are identified by some kind of a probe, and the surgeon will take out usually between 1 and 3 sentinel nodes at the time of the tumor excision. There are a number of different ways that the surgeons can now do sentinel node biopsies. At the time of surgery, they can inject methylene blue dye in the area of the tumor, which will then track up into the lymph nodes, and they can see them as blue. I think that's probably one of their least favorite ways to do it, but they still do it occasionally. It's very messy, and the patient's breast ends up stained blue for quite some time. And then there's the probe-directed ones, either using radioactivity with technetium-99m sulfur colloid, or technetium-99m lymphoseq, which is a more specific tracer, which is taken up onto the surface of macrophages, or by injecting ferrous particles with magnetrace. These tracers can be injected in different ways. You can inject them around the tumor, usually using ultrasound for guidance, not in the tumor because tumors don't have lymphatics. You can inject it subareolar or periareolar as the lymphatic drainage in the breast comes towards the subareolar plexus and then up towards the axilla. You can inject it intradermally like a TB injection, or some combination of these. And the combination methods seem to have a little increased pickup of those sentinel nodes. So that's what we use. So for at DHMC, for technetium, and we use lymphoseq, we inject 1/3 of the dose intradermal, 2/3 subareolar. The intradermal injection is at 12 o'clock, so we don't need imaging guidance. If we're doing magtrace, we just inject the single dose in the subareolar area. So I hope that this has given you a little idea of breast cancer staging for radiologists. We're a very important part of the team, and the more specific information that we can give the rest of the multidisciplinary team, that better that patient can be managed. Thank you for listening.